the first graft choices, there are various graft choices. This includes the allograft, autografts, and synthetic grafts. So today I'm going to talk only on the autografts. So autograft, what is an ideal graft? The ideal graft should be biomechanically, it should be similar to the native ACL, no, native ligaments. It should be easily harvested, and it should not cause morbidity at the harvest or the donor site, and gets well incorporated with the tissue or the bone. So among these, the BTP stands the first. The BTP is one of the oldest ligament was used in the ACL reconstructions. I think many of the younger surgeons might have not seen the BTP harvesting of the graft. So when 2005, when I started my orthoscopic career, the BTP was the graft of choice, and many centers in UK only the BTP was done, and hamstring was occasionally done in few centers. So it is a gold standard for the ACL reconstruction, and BTP is time tested. So just a small video of BTP graft harvesting. So usually the harvesting is done in knee flexion of 90 degrees. So two parallel lines are marked about 1 centimeters apart. The ligament, the patellar ligament is cut, and then the drill holes around measuring about 1 centimeters apart is drilled. So this is to take the stitches to pull the graft inside the joint, and the very important point you need to be noted is you need to use a saw which is thin. So some of the handheld the battery operated saws are that the blades are very thick, so you fracture the bone plugs. So use a very thin saw, and use osteotome, a flexible osteotome. Again, the flexible osteotome is very thin. So by using this, you can avoid the fracture of the patella as well as the fracture of the bone plugs. So after harvesting, usually you harvest the patellar plug first, and then the tibial plug, so that it may not fall down. So after this, you need to take a stitch into the preformed hole of the bone plugs. So this is how it looks when you see in the hand. So the next is the advantages of this bone patella bone grafts. So it allows faster healing in the bone internals because the bone-to-bone incorporation is much faster than the tendon-bone interface. The long-term results, the 83% of in a 2 years follow-up, 83% of the people will have a near normal or a normal knee strength, and it is easy to harvest. The failure rate, the load failure is around 1,785 newtons. The disadvantages, as you know, it's a long incision. It's a minimally invasive incision where you incise around 8 to 10 centimeters in front of the knee, and anterior knee pain is very common. The risk of patellar fracture, risk of tibial tuberosity avulsions, and increased chances of OA when compared to the hamstrings. Why? Because whenever you harvest the graft, some people have tendency to suture the ends of the patellar tendon. So never suture that, leave it free. So once you leave it free, the pressure over the patellofemoral joint will be less, so that the risk of osteoarthritis will be reduced. So the complications, as I said, the patellar tendon rupture, fractures, all those things which I mentioned, difficulty in lean. And the other thing is there is numbness because of injury to the infrapatellar branch of saphenous nerve, and should be avoided in patients who are uses their knee as a kneeling down position for their day-to-day activities. So the next comes is the hamstring graft. This is one of the, again, most commonly used graft nowadays. So this includes semitendinosus and gracilis. Some of them are only semitendinosus, and a combination of these two things. The advantages of this, there is no injury. It is a very minimally invasive. There is no injury to the bones or injury or the fractures, and the graft site morbidity is less. The load failure rate is around 2,422 newtons. So disadvantages includes, it is you are harvesting a semitendinosus, which is a stronger flexor of the knee joint. You may reduce in a highly competitive athletes, the power of the flexion may be reduced. So that's why, again, this is one of the disadvantages. Injury to saphenous nerve. When you are harvesting, if you put your scissors deep inside, you may injure the saphenous nerve, and the patient will have numbness over the anterior aspect of the leg. So the long-term results of 2 years follow-up, there's 75% of the people will have a near normal or a normal range of strength in the knee. Re-rupture rate is around 17% when compared to 7% in BTB, whereas in hamstrings, the re-rupture rate is around 17%. So this is, again, the harvesting technique. This is my own technique where I inject 10 ml of saline into the bursa. So once I inject this bursa, inside this saline, the bursal surface, the sartorius fascia gets elevated, it bloats. So you can easily pick up with the Adson's forceps and dissect it. So once you dissect, there is no injury to the underneath tendons, and you can easily dissect it. This has been published in, just everybody knows how to harvest. Just I want to show this portion, how I dissect this sartorial fascia and harvest the tendon. So like this, I harvest. This has been published in Evidence-Based Medicine in 2019. So this is called hydrodissection. So the indications now the recently many of us are moving to quadriceps tendon when compared to peroneal tendons. So again, it is very commonly used nowadays. It's quadriceps tendons are used whenever we need a very large ACL, when there is a large ACL footprint, and the people who rely on the flexors of the knee, like splinters, athletes and laborers who spend more on their knee flexion and extension, like people who squats a lot. So such people need hamstrings. So that's why the quadriceps tendons has been used. So this is how we harvest the quadriceps tendon. The knee is kept in flexion. Around 1.5 centimeters incision is made over the anterior aspect of the thigh, and the incision and mark the tendon, and incision of about 1 centimeters breadth is taken, and it's incised. It is detached from the patellar tendon. So just a small video. So then the stitches are taken. I cannot fast forward this. So just a whip stitch is taken, and so use a closed stripper to harvest this one. The open stripper, sometimes what happens, it cut through the tendon. So that's why I always use a closed stripper to harvest this one. So everything is done in knee flexion. Whenever we keep in knee flexion, it will be very tight. That quadriceps tendon will be very tight, and it will be very easy to harvest. So incise it beforehand, at least whatever the tendon is available, which is visualized, cut with and dissect the undersurface, whatever the structures are attached to it, detach it, and use a closed stripper. So this is a closed stripper. So push and pull technique, push it inside gently. So once it goes inside, it harvests the entire length of the quadriceps. See, you get a very thick graft. So advantages: lack of the less risk of infection when compared to hamstrings. Injury to the saphenous nerve, again, it is avoided. Low donor site morbidity. One of the disadvantages is prolonged quadriceps weakness and extravasation of the fluid whenever you are not stitching it properly near the joint. And sometimes you may have a rectus femoris retraction. So the peroneus, everyone knows about the peroneus graft harvest. Just I'll fast forward it. And why nowadays most of the surgeons go for peroneus quadriceps graft is because it decreases. See, some people argue for the peroneus longus, and some people are not with the peroneus longus. For the why it is not used is because it is a powerful flexor of the first tray of the foot. So that's why the people who are in competitive sports who uses their foot like splinters, the first tray where the push-off phase is weak. So that's why in the long-term results, the push-off of phase of the first tray is weak. That's why many people are not harvesting the peroneus graft. And also in long-term studies, there is a weakness in the ankle instability. It may cause ankle instability. So that's why many of us have moved to quadriceps graft. So disadvantages: hypoesthesia. Then in 2 cases, they were reported as compartment syndrome and transient peroneal nerve palsy. The graft preparation. So I'll just speed up. Allografts. So allografts are used whenever they need a multi ligament injuries, when the ligaments are less, when the graft you need more of ligaments. So during that time, allografts are used. And patient preference also, you can take it into this. Advantages: less surgical time, predictable graft size, decreased morbidity, and multiple types of grafts available. Disadvantages: cost, infections, diseases, transmission, delayed incorporation, higher failure rates, and lower return to sports. About 43% failure rates are there. Thank you.